So, and Jennifer, if something I do creates too much noise during the presentation, just then let me know as well.
Okay.
Okay. So this is a study that we have just completed looking at the fear of recurrence among women with cancer, and as you'll see, as I'll be describing, it's with women with breast and ovarian cancer, and this was a pilot study for a 6-week group cognitive-existential therapy. So I just, oh wait, okay, it's working. So some other, I'm just gonna, so some of our project team members, the people in the study, we have Cecilia Bell and myself who were the PI in the study. And we also have people from Ottawa. This was a multi-site study, so we have individuals from the Ottawa Hospital and also from people from the University Health Network, Dr. Catherine and Nella Binea, and Mina Singh from York, and Christine Combesson from the CAMH. And then we also had a collaborator from McGill University, but I'm also, like Jennifer said, an associate professor at McGill University as well. And so this will be the usual presentation outline for research studies that I'll be presenting. So some background and context. So in the literature, there's a few definitions that we see. Mostly, fear of cancer recurrence has been described as the fear or the worry that the cancer will return or progress in the same organ or another part of the body. And when you ask cancer survivors what's one of the greatest needs, they will often endorse fear of cancer recurrence, and it's often endorsed by 20 to 70% of all patients. What we find in longitudinal study as well for fear of cancer recurrence is that it's quite stable over the survivorship trajectory, ranging from as soon as a diagnosis is given to 20 years post-diagnosis, people will still endorse fear of cancer recurrence for some. Some background in the review literature looking at some prevalence and scores, some psychological impact and clinical intervention that's been done. So what we find is that fear of cancer recurrence tends to be more prevalent among women, especially women with younger ages and also women with children of younger age. It's been associated with increased functioning impairment or with psychological distress, presenting some stress response symptoms, and also affecting quality of life. Some summary of findings that we have is that among the patients who endorse fear of cancer recurrence as an unmet need or a need of theirs or a concern, there'll be 33 to 56% of cancer patients who will have moderate to high level of fear of cancer recurrence. And like I previously said in the previous slide, it's associated with psychological impairment, so it does affect everyday living. What we find in terms of what's been done out there in terms of addressing fear of cancer recurrence, there's been very little published intervention focusing specifically on the concept of fear of cancer recurrence. What we do find is one study that did look at the fear of progression, which is a closely related term to fear of cancer recurrence, and also intervention looking at the uncertainty. So there's a lot of uncertainty related to living with fear of cancer recurrence, fear of the unknown, and also studies that looked at how can you help individuals cope with some of these fears. But we still have very little understanding in terms of the strategies that's been done to help these participants deal with their fear of cancer recurrence. And what we find as well, so patients who go on to endorse high level of fear of cancer recurrence, they tend to refuse discharge from cancer centers and to be followed up with their primary care providers. They have this feeling that their primary care providers won't be as efficient to find a recurrence should there be one. And they also feel that the letting go from their cancer center is a sense of a loss of safety net. They also tend to be less satisfied with their care. They tend to express doubt, like I said, as though their physician will be thorough enough, and they tend to seek readmission to specialized cancer centers. And then looking at some of the factors that increase fear of cancer recurrence, we find there's internal and external triggers that will increase their perception that one is at risk for cancer recurrence. And some of these internal and external triggers, as I'm sure you can guess, will be having aches and pains, headaches, feeling bumps, external triggers, a next appointment for a medical checkup or cancer screening, hearing of someone else going through a recurrence or a new cancer diagnosis. So there's also the lack of knowledge about having difficulty differentiating between what could be a possible sign of a recurrence versus benign symptoms. That's also been documented. And also having inappropriate coping strategies such as checking behaviors, constantly checking their bodies for new bumps, for new aches. Sometimes it's been documented that people would do it from one time a day to multiple times during the day, and also seeking excessive amounts of reassurance, either from people around them or from their healthcare providers. So constantly calling them for, can they have another appointment? Can they be seen again, just to make sure that what they're feeling is not a recurrence. So in terms of gaps in literature, like I think I mentioned also, there's very few published interventions specifically addressing fear of cancer recurrence. Currently, there isn't any. There's the one that looked at fear of cancer progression, but specifically for fear of cancer recurrence, we have one study that's being piloted at the moment in Australia, and then there's the one I'm going to be presenting that we did some pilot work that was specifically addressing fear of cancer recurrence. And considering the amount of people that endorse fear of cancer recurrence, we do believe that the gap is that fear of cancer recurrence intervention should be part or included as part of survivorship care. When we look at some therapeutic modality geared in terms of group intervention, we see that group cognitive-existential therapy has been tested among breast cancer patients by Cassane, and that did help in terms of improving their anxiety level and also their quality of life. We find that group therapy, as opposed to individual therapy, tends to be more cost-effective. It's been proven to be as efficacious as individual therapy and offers unique elements that provides further support to individuals, such as universality, feeling that, or seeing rather, that they're not the only ones having these feelings of fear of cancer recurrence, and also that shared learning that happens in group settings and the altruism aspect of being able to help each other. Cognitive behavioral therapy has also been many times proven to be an effective treatment for anxiety and mood disorders, and has often been used with cancer patients. The existential component that was added with the cognitive existential therapy by Cassane addresses further issues such as the fear of dying, fear of suffering should they have another cancer diagnosis and go through further treatment, and the fear of being alone, and then some specific fears that are typically seen with fear of cancer recurrence. But these are often fear of suffering, fear of leaving the children, and being alone are often the ones that are being cited. So when looking at a specific framework to guide this development of intervention, so Sophie and I, we sat down for over a year to develop this intervention, looking at the literature that I just presented and looking at what some of the known predictors in the literature that could help us inform building a framework to build an intervention. And we had, and then based again on the literature that we found, we added the internal and external triggers, which were showing to increase their perception of personal risk of cancer, which then feeds onto their fear of cancer recurrence. And then when they have these internal and external triggers, it was found that often having that lack of knowledge about possible symptoms of recurrence also fed on into the having the difficulty in terms of differentiating what could be a possible return of cancer. And then there was also on the right side the intolerance of uncertainty. I apologize, I knew this was going to happen. I'm at home. A second. So the intolerance of uncertainty. Give me a second. All right. So the intolerance of uncertainty relates to people who find it just unacceptable that should they have any form of uncertainty in their life, and this relates to feeling unfair that they should have, feeling uncertain should they have a recurrence or not. And on the left side, the faulty beliefs about benefits of worry, what we found again is that people who tend to think that I need to worry constantly and every day in order to prevent or to at least be able to detect myself as cancer, as again, not having that trust that their doctor can do themselves. And then below, with the body checking, reassurance seeking, and avoidance of fear outcomes, again, people who tend, the more they do body check, the more often that tends to increase their fear recurrence. And also, reassurance seeking constantly tends to, again, feed on increasing the fear recurrence. And trying to avoid the feared outcome or avoiding the thoughts that bring about the fear about a cancer recurrence tend to feed on the fear recurrence. So building on this framework, we went on to develop our study, pilot study with the purposes and the hypothesis following. So we went out to test a pilot test the development of a standardized cognitive-existential group intervention designed to address fear of cancer recurrence among women with breast or ovarian cancer. And then the hypothesis was that women attending a group intervention that addresses fear of cancer recurrence would demonstrate improvement in fear of cancer recurrence, cancer-specific distress, uncertainty, coping, and quality of life as measured pre and immediately post-intervention. And we also hypothesized that improvement would be maintained at 3-month follow-up. So some of our methods here. So we designed to have a pre-post assessment and a 3-month follow-up, and 6 group of 6 to 8 women each with a minimum sample of 37 counted as an effect size that was calculated based on the impact of event scale, the IES distress for cancer patients. We started recruitment in 2010. This should say 2000. We stopped in 2000. We finished in 2012. The last one at the bottom was in the summer 2012 that we completed the last group and had the 3-month follow-up completed. So in October 2010, we began the group of fear recurrence at Princess Margaret, which was then followed to the Ottawa Hospital. The Ottawa Hospital conducted all the ovarian cancer groups, and at Princess Margaret, we conducted all the breast cancer group interventions. So the intervention goals was to help individuals, again, based on the literature, to distinguish worrisome symptoms from the benign ones, looking at identifying the triggers and identifying inappropriate coping strategies, and changing those to more appropriate coping strategies, facilitating the learning and the use of new coping strategies such as relaxation techniques and cognitive restructuring, helping them to increase their tolerance for uncertainty, promoting the emotional expression of the specific fears that underlie their fear recurrence, and helping them re-examine their life priorities and helping them set realistic goals for the future. And then again, like we said, in the cognitive-existential therapy, we did want to emphasize authentic living, the freedom of choice, confronting life for existential themes such as suffering and dying. And we also discussed anxiety about that, future goals, and then living with uncertainty. And this is just an overview of the 6 sessions we had. Without going through each one of them, specifically in session 1, we introduced the model of fear recurrence, the one that I just presented earlier in terms of our framework, and we provided them with we provided the woman with information about symptoms of recurrence for breast or gynae, depending on the group they were in, and starting to help them distinguish between benign symptoms and malignant symptoms. And this was done in session 2. What we did is that we had a healthcare professional, a specialist in breast cancer care nurse, who came to provide this 30-minute presentation on possible signs of symptoms of recurrence, and then patients were also encouraged to bring some of their own questions they had. In the session 2, we introduced the idea of uncertainty, how that's unavoidable, and how could they try to live with the uncertainty, but rather not to eliminate it, but how can they better tolerate it and manage it. And then we also began teaching the participants different relaxation techniques. They were provided with a relaxation CD in the first session, and were provided with guidelines on how to use it as well and how to practice it at home. In session 3, we looked at challenging some of their false beliefs about the benefits of worry, and we also introduced the idea of decreasing their maladaptive coping strategies, such as the constant body checking and reassurance seeking. Oh, sorry. In session 4 and 5, we reviewed some of the progress that they had done in terms of going through cognitive restructuring and relaxation techniques, and how can we enforce the importance of decreasing their use of maladaptive coping strategies. We also promoted the emotional expression of the confrontation of their specific fears that underlie the fear of recurrence. So we call that one of their most difficult case scenarios. And then we provided them with some homework so they could go through some of that scenario, and then we helped them process the affect in the following session. And then in the last session, 6, we review what was covered, and we help them to move forward in building new goals and priorities. So in order to be eligible to participate in the study, the individual had to do some screening, and they had to endorse fear of cancer recurrence on the questionnaire, fear of recurrence questionnaire by Nordhaus, at least 4 and 50% of the items with a possible range of 1 to 5. We wanted an individual with high level of fear of recurrence and distress. So on the impact of event scale, they needed greater than 24, where the clinical cutoff is 23. It was either diagnosis of breast and ovarian cancer, and in this one, what we aimed for was having the same gender. But what was common to both groups is that we wanted an individual with high levels of fear of recurrence and anxiety, since that was the main focus of our intervention. And they had to be completed with their treatment, by exception with hormonal replacement therapy. And the exclusion criteria was self-reported psychiatric disorders or depressive episode or untreated depressive episode, refusal to provide informed consent, and the need to be able to understand and speak English. So once they met the criteria, everybody went through a pre-interview session. So after they had agreed to participate and sign the consent, each individuals were asked to attend the pre-intervention session. And in this one, we discussed what was the major goals of the intervention, what was the expectation, and again to see if those expectations met their expectation, and to see if being in a group setting was really for them, and if they wanted, perhaps if they thought if there would be a better fit for them for individual session, then they were encouraged to seek out individual session with the psychosocial oncology team. And in each session were videotaped so that we could assess if the intervention was done in the same manner for every group. And then we also had a subsample of women that we asked if we could do an exit interview to further assess the satisfaction with the intervention. So in the data analysis, we had repeated measure analysis of variance across time for pre and post in the 3-month follow-up. The primary outcome was the fear of cancer recurrence measured by the Nordhaus Fear of Cancer Recurrence questionnaire, which has the 22 items looking at worry about health, status, illness, returning, possible triggers, and uncertainty. Then we also measured the secondary outcomes with cancer-specific distress, looking at the IES, looking at acute cancer-related distress. We used for coping the brief cope with the 14 coping subscales with two item each. We used the uncertainty and illness by Mitchell for the uncertainty, and then for quality of life, we looked at impact of cancer scales with the 10 subscales, and then with the that has 2 major scales of negative and positive quality of life. So some of the findings, we recruited in a sample, we had 87 who were screened for eligibility. And if you look at the bottom, out of these 87, there were 38 women not enrolled because either not met the criteria or also because they could not commit to the timeline. So that's what we also discussed in the pre-interview session, where they were told that this was a It was a closed group of 6 sessions, and then if they missed more than one session, they would be withdrawn and asked to join in the next group. And if they missed one session, then we would follow up with them to complete that session either by phone or in person and give them and then help them to complete the assignment before they return them the week after. And then some did decline after the intake interview, feeling group sessions were not perhaps for them. So overall, we enrolled 49. We had 39 for breast from UHN, and then 10 from the Ottawa Hospital for ovarian cancer, women with ovarian cancer. The intervention was completed by 28, so we had some dropout in this one, which I'll explain in the next slide. And then 9 for the ovarian group, and then for a total of 37 who completed the intervention. And then we had 36 who completed the time 2 measurement, which was immediately after the intervention, and 33 for the 3 months follow-up. So some of the reasons for dropping out, some actually felt, what we learned after especially with the breast group, is that some women felt that their fear of cancer recurrence was getting worse. So it was, especially in the first 2 sessions, where we realized when the nurse in session 2 was coming to bring some presentation on the possible symptoms of recurrence, some of them, although were perhaps not prepared enough for that presentation. And so what we did in the 3rd and the 4th group following up is that we prepared them for what was coming in terms of the content of the presentation, but we also asked them, the breast cancer nurse, to water down some of our presentation and be a bit more general, especially since whenever they did have a worry if a cancer was returning, we always advise the patient to go back to their healthcare team. Some of them felt that after the first session, because we delved into the topic right away of the recurrence. We expressed to them the group was not to be exchanging treatment option or treatment experience or doctor experience or nurse experience, but was the main focus on fear of recurrence, and that we would be working through those. And so for some, they felt it was just too difficult it was a 90-minute session to be thinking about cancer for that time. And they felt they were perhaps thinking about cancer more often after the first session, although we did tell them in the second session, in the third, we'd be providing them with more coping strategies to deal with those anxieties. But some decided to drop after the first session, which was where mostly we had some of the dropouts. And then also, like I said, some people found they had difficulty scheduling all the sessions, the 6 sessions, which were consecutive. And if they fell off one, then they had to be withdrawn. And then we had a few that had some personal illness not related to cancer, which made it they couldn't continue. Okay, so some of our demographics for those who did complete the intervention. So the average age was 53. We had individuals as young as 34 who participated, and is up to 72. The time since diagnosis was mostly about 2 years. Most were married. It was a high university group, highly educated group, mostly university educated. This intervention was done downtown Toronto and in Ottawa, as well as the downtown Ottawa. Cancer stage, we accepted everybody from cancer stage 1 to 3, and this was pretty much similar in all those 3 stages. And cancer diagnosis, we did more groups with breast and ovarian, so 3/4 are with breast and 1/4 with ovarian. Okay, so some of our major findings. So when you immediately following the intervention, so what we found is that for fear of recurrence, we had, I jumped one slide, or there it is, okay. So changes in outcome in terms of from time 1, pre-intervention to post-intervention at time 2, and then at time 3, we had significant findings for fear of cancer recurrence with a large effect size of 0.76. For cancer-specific distress as well, we had significant findings with low to medium effect size of 0.34. Uncertainty, we also saw a decrease of uncertainty level, again, was significant. In terms of the coping scales, the use of emotional support coping, we saw also an effect size of 0.28. For positive reframing, we also had significant findings in terms of an effect size of 0.41, and that was thought through the cognitive restructuring. And the accepting coping as well, we saw significant findings as well in that one of 0.35. For the quality of life, we didn't see an improvement in the positive quality of life scale, but in the other subscale for negative quality of life, we saw an improvement in the negative quality of life where there was less of impact. For immediately following the intervention, again, this was we had significant findings for fear of recurrence, cancer-specific distress, again, uncertainty, the same one, emotional support coping, positive reframing, acceptance coping, and negative quality of life. And as a 3-month follow-up, so all of the changes were maintained, so we didn't see a difference from time 2 to time 3, which was a good sign. The only one that we did see a change was for the emotional support coping, that we saw a decrease. So possibly not being in that component where the individuals were meeting regularly could explain for that decrease in the change of emotional support coping. Although some participants did tell us they continued to meet, maybe not on a regular basis, but they did exchange numbers and continue to meet. We also have done qualitative interviews with some of the participants, breadth and ovarian. And so what we found in terms of suggestions for improvement is that the women were saying that they felt that the number of sessions was adequate, but they wished there was more time to discuss some intense topics. And we did notice in sessions 4 and 5, when we do discuss some of their most difficult scenarios, and then how can they reframe it into a more positive light, people would have needed a bit more time to process the affects in the group. It was a 90-minute session, and because it was set and we told them it was a 90-minute, we tried to respect it as much as we could, so that often we felt that ourselves as leaders, that 2 hours or 120 minutes would have been more beneficial. It also depended on the size of the group. Sometimes if the groups was 4 women, then we had enough time with 90 minutes. When we had as we went on with the groups, there was less dropouts. So if we started with a group of 7 to 8, that's when we would have needed more time. They also liked a in-class exercise for the cognitive reframing and relaxation exercise. They'd like to continue in the class as it gave them a practice on how to do it themselves at home. And also, as we knew, they asked to soften the healthcare providers' educational symptoms on the symptoms of cancer recurrence, which we did in the process to minimize a bit the dropouts. In terms of one of our PhD psychological student in the Department of Psychology at the University of Ottawa, she retook our pilot, our group intervention, and tried it out on an individual to test out a case study because she'd like to do it with a group but with a different type of cancer. So what she did was just an individual intervention, and I'll present some of her findings, although it's hard to extrapolate some of her findings from one person, but it's also interesting. So this was a female, middle-aged, diagnosed with breast cancer. She self-reported as being very anxious, and she said that she kept thinking about her cancer coming back, and she was referred from the Center of Psychological Services and Research at the University of Ottawa. So a primary outcome measure, she used the same questionnaire that we used with Norhouse for the fear of recurrence questionnaire. Her secondary outcome was the cancer-specific distress measured by the impact of event scale, so the same as that, but then she used the exact depression inventory for depression and anxiety. This was an indoor session. She still used the 60 to 90-minute range. In session 1, 2, and 3 are lighter, like I had said before in session 6 as well, which she did a 60-minute, and then session 4 and 5 was the 90-minute session that she used. again, just to be having more time to address some of the delicate nature of these sessions, those sessions, looking at the specific fear and looking at exposing the person to a difficult case scenario. And instead of a visit from the healthcare professional in this session 2, she asked the person to prepare a list of questions for her oncologist and to bring them to the next follow-up appointment, which was scheduled. And the client had felt this was a very useful exercise. And the intervention was focused more on the individual, so there was more time to complete all of the exercise and promote the process of emotion. And there was more time spending on looking at positive coping strategies, what specifically were her coping strategies that she's used in the past, and how can she use them in her present tense to address her fear of recurrence, and how to engage also in calming self-talk. So again, this is something was taught in our session, calming self-talk phrases. Either there's been some empirically proven calming self-talk phrases that have been tested out, or we encourage the participants to formulate some of their own. We had some groups who formulated group calming self-talk that they would use within themselves. And then we helped them as well, like she did, identifying priorities and listing their specific fears and how do they feel they can regain control over their lives. So what she had found in this one case study is she did see an improvement in the fear of recurrence. There was a decrease in all of the measures. And although fear of recurrence was just a decrease of 6, it's still a decrease, but this person is still above what with the fear cancer recurrence, if there's no clinical cutoff known or set, we have set it at 44, but this person is still relatively high. However, our distress score on the IES, which there is a cutoff at 23, she's still now below the clinical cutoff. And as for the BDI and the anxiety inventory, she also has a decrease in both components. So what she's found in terms of her case study is that the cognitive-existential intervention did help the individual improve her cancer-specific distress and her intrusive thoughts. The client felt that she no longer engaged, or at least less engaged in avoidance, and she felt stronger and felt better to manage her fear of recurrence. She said she also benefited greatly from the most difficult case scenario exercise and the relaxation techniques. And that she said, however, that although the 6th session was effective, she would have liked perhaps a few more sessions, so going through like additional sessions. And then the student now wants to pilot this intervention with colorectal cancer patients. So having more sessions was also something that we did see in our group. Some of the women did said it was either increasing the amount of sessions or the length of sessions. So in terms of some of the discussions, so like I said, we finished writing up our paper and we have submitted it to be published. So we're waiting for their reviews. But this would be the first published intervention specifically targeting fear of cancer recurrence, and one that has been at least showing some efficacy in terms of providing cognitive-existential group intervention to influence the level of fear of cancer recurrence. And our study was able to provide some evidence for a moderate to large effect size. And then looking at the feasibility of the intervention, this is a standardized and manualized intervention. So we have developed a manual for both the participants and the group leaders. And I say group leaders because the group interventions are always given by 2 individuals. Everybody who gave the group interventions were trained by by 2 of our psychologists who have training in cognitive behavioral therapy, and and everybody followed the same manual. We did have effective recruitment strategies, although it took a while at the beginning, but it was mostly by having posters around specific areas close to cancer clinics, breast cancer clinics, ovarian cancer clinics, elevators. But also within the Princess Margaret, we have within our Cancer Survivorship Center when they go through their intake interview with the Survivorship program, they're being asked, do you experience recurrence? And if they check off yes, then they offer, would you like to take part in the study? And then they will refer to us. So people self-referred and called us in, and then that's when we did the, we screened them for eligibility. There was also favorable interest. So there are a lot of people requesting this intervention. There still are. We still have individuals on the waiting list for the next group to start that they would like to participate. And what we also like is that we were able to recruit individuals with high level of fear of cancer recurrence and distress and still be effective. And then we were also happy to show this was a 6-week intervention, whereas like the Cassane study where he did with cognitive-existential for breast cancer patients was over 20-week session. And most group intervention we see for helping for anxiety level and coping are mostly geared around 8 sessions. Of course, there are some study limitations to this study, so it may not be suited for all cancer patients. There was some dropout, and we try to minimize that. That's when we try to do the pre-interview sessions, going through some of the lists of what was going to take place, some of the topics that was going to be addressed, and if this was meeting their expectations. So perhaps there's some improvement to be done there in terms of putting it more forward the reality of the group session and what would be discussed. We had also counted the one-time miss as a dropout, like I said, so there was a few who missed 2 sessions and were asked to continue to the next group. Women were not randomized, so it's hard to clear-cut to say if what we found is really due to the intervention, but we are intending to move into a full RCT. We've applied for funding a few times. We came in close, so we're reapplying actually this year and hoping that we will be able to obtain funding to continue the study into an RCT. And also the current fear of cancer recurrence by Nordhaus, the scale we were using did not have a validated clinical cutoff score, but at the time that we did the study, that was the best measure there was. But now we do have the fear of cancer recurrence inventory that's been validated. And it does contain a clinical cutoff score that we intend to use for our RCT. So in our future directions, we do intend to investigate more the mechanism of the change of the intervention, what exactly is specific in the intervention that brings about some of these changes. Because again, in the other study by our first track, looking at fear of progression, he also concluded that some of those therapeutic agents that were common to both approaches that he tested, which was cognitive behavioral therapy and supportive expressive, although effective, he was still unsure in terms of what specific changes took place, what specific agent took place to bring about those observed changes that he saw. And some of just general implications for practice. So we feel that once we publish our pilot data, this will provide some basis for our future implementation of putting forward an evidence-based intervention to help address all types of cancer patients dealing with fear of cancer recurrence. And because we have a standardized and manual manual for both the patients and the group leaders, we also feel that this group training can be made available to other healthcare professionals working with cancer patients. And but we would recommend considering extending the length of some of the sessions from 90 to 120 minutes or all of the sessions. And we are also considering for the RCT adding a booster session after this, instead of making it into a 9-session or 8-session, keeping the 6 sessions at 120 minutes for the booster session after the last session being done. So in the end, with the intervention, we had hope, and the intention was to help the individuals be able to acknowledge some of their fears and be able to talk about it instead of trying to avoid the elephant in the room, which was their constant fear of recurrence. And then helping them to see where can I prioritize my life and be able to live my life for what it is and not just focus on my cancer recurrence risk, and then learning those signs of recurrence. And also understanding that having all these different emotions is normal, and that after a treatment, they are feeling different, like many acknowledge. But how to also get help when these emotional stresses are above what they can do within their own coping strategies, and then helping them to focus on the present, not just being frozen by it. So we hope that's what we have been able to achieve. And so before I end, I'd like to make some of the acknowledgements for this study. So we, of course, the participants from both Princess Margaret and the Ottawa Hospital who gave us the possibility to test out this intervention, and all the healthcare professionals who helped us recruit and look after these women. And this is a picture of one of our participants who did the Right for Cancer, to Conquer Cancer. And on her paper, she has some of those calming self-talk phrases that the group came up with that she rewrote on her paper to give her that strength to do this run. And also, it says that she's running for her group for her Fear of Cancer Recurrence group. And then we're thanking our recruiting site. And we also had Mount Sinai who had agreed to participate. We had REB, but the study got rolling, and we ended up having an updation, which is the 2 sites. So for the RCT, they will be participating. So I thank you. So I'm open to questions at this moment.
That was wonderful, Christine. That was a wonderful presentation. If other people have questions, just unmute your microphone.
Everyone is unmuted right now.
Oh, everyone's unmuted now, so you can ask questions.
I have a question and a comment. It's Joanne Stephen calling from Vancouver. Christine, that was I really enjoyed that. What a wonderful, wonderful intervention, so specific, and it really looks as though you know what we hope to see in cognitive behavioral interventions with regards to getting very specific.
The stream of emails, and I realized Marty might not be there until 9:30, and I realized maybe too late. Okay, we're all good. Okay. Thank you so much. Bye-bye.
Yeah, I didn't hear your question.
Okay, sorry, I wasn't quite sure what happened there. Just to, but it looks very much like quite a powerful cognitive behavioral intervention where you've been able to identify specific elements of the fear and then really quite effectively extinguish the fear with the use of you know, relaxation and emotional processing. Really, really wonderful. I was interested I know it's a small sample, so you probably aren't able to look at that, but I did think it was interesting that you had women at stage 1, 2, and 3, where the sort of realistic aspects of fear of recurrence obviously become heightened at stage 3 compared to stage 1. So we're not just talking about dysfunctional thoughts here at all, but quite realistic fears. Was there any sense of differences amongst participants with regards to stage?
Honestly, Joanne, we didn't. It's a good question, and out of curiosity, I should go back and check out to see if there were differences. Because there was a small sample, we didn't subgroups into the different types of diagnosis. But the intent where we did want to include everybody from stage 1 to stage 3, because again, from the literature, we're showing that it's not so much a strong predictor of fear of recurrence, the stage, for more certain other ones like the person's age and having children. But the stage of cancer was not a robust predictor of fear of recurrence. So our main thoughts was let's include them all from stage 1 to 3 together, where the denominator in the group, and again, was the focus on their level of fear of recurrence being moderate to high. And in the intervention group, in the first session, we set it up where people did present themselves in terms of the treatment they had in the stage, but we told them we would not be focusing on the treatment or the stage of where they were. We were focusing on their level of fear of recurrence and their anxiety. And that seemed to have worked in terms of putting everybody on the same kind of, feeling kind of equal.
Very nice. Thank you.
You're welcome.
So, Margaret, your you want to ask your question, you can unmute your mic and ask it.
Hi, it's Margaret Forbes. I just don't know if my microphone is working properly.
Yes,
from
we can hear
Hamilton,
you.
Ontario, Canada. I'm just wondering if you conducted subgroup analysis to determine if there was any difference between the ovarian and breast cancer patients.
So we have, and there was no difference between the two. Although the ovarian group was small, we did conduct those. Our statistician, we did ask them, and there was no differences between the two. The only difference we saw was more in terms of the dropout rates, where they had less. But it just seemed that the way their ovarian cancer nurse was delivering the intervention was a bit more, I don't have a better word than watered down, but otherwise there was no difference between the two groups.
Okay.
Thank you.
Thank you.
Christine, this is Jennifer. I have two questions. So first of all, in terms of getting at the mechanisms of change and understanding what's accounting for the changes, did you get any data from your qualitative interviews that might help you in that regard? And my second question is, do you think, having run these groups, that this is something that could lend itself to online delivery, like say through Cancer Chat Canada or something like that?
Okay, so I'll answer the first question. In terms of, yes, with the exit interview, the qualitative interview, so, and also I'm still seeing some of the patients that are stopping in the hallway and telling me what really was helpful for them. Learning these coping skills, so a lot of them felt that they had never stopped to really try to see, you know, can I do mindfulness exercise? Can I do relaxation exercise or grounding work? So in the session, we always made sure that we practiced at least 2 different kinds of relaxation exercise and the use of calming self-talk where they could have something instantly. Let's say if they were at their doctor's office and feeling that fear of recurrence going above what they could handle. They had calming self-talk phrases that we helped them formulate in the session that they could immediately use without having a relaxation CD or having somebody to help them prepare to relax. And so they felt that that gave them immediate tools for dealing with their anxiety. And also the cognitive restructuring of their thoughts. So helping them, what could be a better reality? What could be, how can you restructure those thoughts to be a more positive thought? Again, that reformulation of negative thoughts and always seeing the worst outcome in everything really was something that was really helpful for them. So that's why in sessions 4 and 5, when we deal with a lot of these issues, we would like to expand a little bit more so we could have more time to process everybody's affect, but also exchange in each other's strategies on how they used it. So the learning about restructuring their thought was something that was very mentioned as something very helpful for them. Learning these relaxation techniques and going through the most difficult scenario where they felt they would not have done it if they had not had received guidance from us, and then a follow-up in the next session. They felt that we were holding their hands throughout those 2 difficult sessions where they could do it. Some people felt, some people chose not to do it, and so again, that was brave, and we embraced them in a group for their decision, and that was the best for them. But in 90% of the individuals, they all did it, and they felt those 3 aspects was the most beneficial. And for your second question, in terms of building an online support group, so actually we are preparing a grant to this effect that we're planning to submit in January. We're definitely going towards the trustee to see if we can test out this online support peer recurrence group and see how it can be as effective as face-to-face. So that's our next step. So the next step is the RCT and the online testing. It's coming. It's coming.
Great, thank you. Are there any other questions?
Hi, Christine. This is Angela Bedard from Vancouver. Great presentation. In terms of just a little bit similar question to Joanne Stephen, in terms of women's perception or fear of recurrence based on their actual risk, it didn't look like you collected data on if the women had hereditary breast or ovarian cancer. I'm just wondering if you did and that wasn't reported. And secondarily, what your knowledge is that from the literature, does that predict women's fear of recurrence if they have, say, a BRCA mutation?
Yeah, I actually noticed here. So I've done previous studies with women who are at increased risk for breast and ovarian cancer with the BRCA1 and 2, and I've actually done another study, which I'm going to be putting the publication forward soon. It was an uncertainty intervention study to help deal with, these was for people going through BRCA1 and 2 receiving inconclusive results, and still being uncertain about their possible inherited risk and their possible cancer risk. So for these individuals, yes, perception tends to be rather high, and perception of risk for cancer or hereditary breast or ovarian cancer for this other study tends to be difficult to be changed, but it was changed in that other study because they did receive inconclusive, so they felt their risk was lower for a possible inherited mutation. For the cancer risk, it didn't change, and although the intervention was focused to try to see if we could maneuver within that. So in this one, we did not measure it, but I don't, it's fairly unlikely that the perception of the cancer risk was decreased by just this intervention, but it's hard to speculate because we didn't measure it, although I did measure in the other studies. So it would be a different component altogether, trying to, and it would be great as well. I'm thinking I should do it. Retrying out this intervention, but for hereditary breast or ovarian cancer patients. But I think a lot more would have to go into it, especially about the supported expressive parts, because their risk is so real. It would require a lot more thought through in terms of how it would need to be reorganized or rearranged to fit their particular needs for the HBOC group.
Well, great, thank you. Look forward to that in the future, maybe.
Yeah, maybe, and it's a good thought because, I mean, they definitely need it. And, of course, they're, once they have it, already their cancer risk is so high that once they have it, and if they were, they've managed it, and their cancer recurrence is mostly possibly quite higher than the general groups without cancer diagnosis. And in this study, no, it was not something we collected in terms of if they had a genetic mutation. And I'm trying to see if somebody had mentioned, because I would have been attuned to it since I've done work in this group, but nobody did mention. I'm trying to see if I can do a demographic, but I don't think it was something we collected. It would have been interesting. Yeah, good question.
Okay, well, I know, Christine, you have to go to a CAHR meeting, teleconference, so we're gonna probably end now so that you have time to do that. I thank you so much for your time today. It was a wonderful talk. And for those of you on the line, this will be our last rounds until September, so enjoy your summer, everybody. And the rounds will get posted on our website if you'd like to share that with other people, colleagues, so on the Elixir website. So thank you very much and have a great summer.
Thank you.
Thank you. Bye-bye.